Hans, you're hard at work as always.
Yes, but I found a quiet spot, and hopefully I can attend from beginning to end without interruptions.
It's great to see you. You've so dedicated to the sessions. It's so nice to always see your name and face.
But you learn so much from them.
Yeah, always do. Should we kick things off?
Let's do it. Do we have someone who has a case?
Uh-huh.
Yay.
Elena.
Yes. Should I get it started?
Yeah, do you want to say hi to the group in case
Yes.
people don't know
Yes,
you?
for sure. Yeah, in case you don't know me, I'm Elena. I'm part of the CP Solvers Academy. And I'm here for two reasons today. One, to hear Steph Zaven's magic, but also to, as part of the leadership team, I really want to encourage you all to submit your cases. So if you have seen an interesting case in the clinic, then really feel free to approach us. We have a committee to review those cases. And we really don't want to see Rosé-Darfman's disease or anything like that, but just bring your simple pneumonia. We'll be so happy to discuss those cases with you. And yeah, Sasin, if you want to share your screen, then I'll share the first aliquot. Awesome. All right, so the case I'm going to present has a total of 5 aliquots, with the last one revealing the final diagnosis. All right, so the chief complaint is fever, confusion, and rash. A little bit more on the HPI. We have a 48-year-old female who presents to the ED and reports that she felt well until 5 days ago, when within a few hours, she developed fatigue, nausea, diffuse whole body pain, a headache, and subjective feeling of fever. She denies any other accompanying symptoms, in particular chest pain, dyspnea, cough, abdominal pain, diarrhea, or urinary symptoms. No one in her environment has fallen ill, and she denies having recently traveled. When talking to the patient's partner, she reports that the patient has been intermittently confused for the past 2 days and was, for example, not able to recognize the day of the week. And I will stop here.
Thanks, Elena. I am concerned about this patient. We don't know the past medical history yet, but whether there's some kind of notable background, or even if this was a completely healthy patient, the presentation sounds very acute and very severe. Severe because her brain seems to be affected. And the way in which it seems to be affected seems to be a systemic illness that is affecting the brain. And the systemic kind of part of it is the body aches, the fever, which are most consistent because of the time course with a severe and kind of fulminant infection, and most likely a bacterial infection, given the sort of acuity and severity of illness. So I think a distinction I like to draw whenever there's sort of an infectious syndrome that has not yet been localized and encephalopathy is the sort of commonness of the brain being affected even when the infection isn't in the brain or around the brain, which often happens in older individuals or in those whose brain is not normal at baseline or sort of particularly prone to dysfunction. So if an 80-year-old person with a history of dementia has fever and confusion, that's not very localizing to the central nervous system as the source of the infection. By contrast, if we learn that this 48-year-old person indeed was previously healthy and, you know, working and everything, and if she's acutely febrile and confused, that will be a much more sort of concerning signal that the infection may be in or around the CNS, kind of more directly affecting the brain parenchyma, specifically kind of invoking potential meningitis, encephalitis. And that kind of goes for the headache too. You kind of, you know, headache is a common sort of bystander symptom of many systemic illnesses, can be part of viral syndromes or just sort of a stress reaction to infections elsewhere. But if it is very prominent, and if there's exam features, also suggesting sort of tension in the surrounding muscles, and that would be more concerning for a CNS infection. So those are my initial thoughts. Kind of definitely raising red flags about severity of illness and importance of kind of aggressive diagnostic workup as well as empiric therapeutics in parallel. And we can talk more about sort of the necessary sequence of that. But also just that key point of, you know, you can often invoke meningoencephalitis. And I think altering the pretest probability depends on the propensity of the given patient to develop encephalopathy from distant infections, as well as kind of the amplitude of the CNS symptoms, which also kind of potentially point towards a CNS source more versus less strongly.
Yeah, well said, right? Headache and confusion don't mean the problem is here, right? That may be a bystander. I'll say two things gave me pause with what we've heard from Elena so far. She's relatively young. So you gave the example of an 80-year-old who gets you know, urinary tract infection and has it. Doesn't mean she can't still feel unwell in her head from that, but her age of 48 strikes me as younger than one would expect from innocent bystander confusion, but certainly not impossible. And then this sort of acute, but like also in the hours of suddenly feeling really bad, that like hyperacute evolution on the background of 2 days of confusion. It just made me ask the question, when we use the MIST schema for thinking of reasons someone's confused, which categories are very, very rapid in how they evolve? And truthfully, all of them can be. You know, a lot of the metabolic in terms of electrolyte issues, though, I would not expect over hours. We're going to get labs in her anyway, so we're going to have quick answers in terms of if the magnitude of any lab abnormalities sort of fit the magnitude of her confusion. Certainly infectious etiologies, whether primary CNS or not, can be very rapid, but encephalitis onset can be pretty quick. And then structural things, right, can happen like that. If you have a brain bleed, right, that's a very hyperacute vascular event. Doesn't quite seem to fit here, given her kind of systemic symptoms. And then the toxin category, I think right off the bat is appealing to me for suddenly making someone feel so sick and confused. Is there an exposure? Is there a withdrawal? So truthfully, I was thinking in my mind as Zaven was chatting, like, ooh, does the time course help us narrow down those categories? Not a ton, I don't think. I think it's very, very broad on what could be going on. And just love the point that we have to be worried about primary problem here or just somewhere else in the body where the brain is being affected. But yeah, she's relatively young. We'll find out soon if she's healthy, but it's very concerning how rapidly she's getting worse over just a few hours. Give it some more, Elena.
Great, I love the discussion, and I love that you highlight that like 3 out of the 4 MIST are like extracranial, so we have to worry about intra and extracranial causes. All right, so for the second aliquot, the patient has no known pre-existing conditions, and the patient also doesn't take any medications on a regular basis. She doesn't drink alcohol, denies smoking or any other substance use. She lives with her partner on a farm in New Mexico with cows, sheep and 1 dog. She says that she's often at in the fresh air and also goes hunting in the forest. When asked, she cannot recall any ticks or mosquito bites. Yeah, and I'll move on to the initial vitals. So the temperature was 39.1 degrees Celsius on admission. The blood pressure was 110/70. Heart rate was 110 per minute. Respiratory rate was 25 per minute. SpO2 was 96% on 2 liters nasal cannula. On examination, the patient appears lethargic and sweaty. She's disoriented to time and place, but not to person. She has like a slow speech, but like follows instructions adequately. Occasionally, she makes like nonsensical sounds, but no dysarthria or aphasia is appreciated. The pupils are medium-sized, equal, and promptly reactive to light. There are no other focal neurological deficits. The skin, including all extremities, is warm to touch. Strength and reflexes are within normal limits, and lung, cardiac, and abdominal exam actually showed no pathological findings. And I would actually like to share my screen for a second to share one skin finding that was appreciated. Here we go. Can you see that? Right. Yeah, maybe you can take us through the skin finding and then.
It's so we're looking at her abdomen. It's I see Mahmoud is mentioning the chat like livido-reticularis. It's reticular, right? It's sort of coming from the word root of net like. There's some subtleties though. It's not diffuse. So a lot of systemic dysfunction that can cause sort of microvascular dysfunction when you're really sick can cause livido-reticularis, but it's usually like pretty diffuse. And I'll just note that this is fairly localized. It's irregular, it's asymmetric, and not all the little net-like prongs close. So I think it's a good thought to have that on there, but it generally sort of should worry us, I think, potentially about a vascular phenomenon, but I'm struck at like how localized it is. I think we can see a little bit on her left flank also, on her left side, but she's not totally and diffusely modeled to suggest that this is from like just being super sick with all her small blood vessels sort of not working well. So yeah, Mahmoud is mentioning, right, there's this other livido, which is racemosa, which is where these net light projections don't close. The pathophysiologic difference there is racemosa is usually from small vessel dysfunction from something embolic, whether it be a little piece of clot, a massive tumor or something, and it's a much more localized phenomenon. So I think we'll definitely call it a reticular rash. Whether it blanches or not, I have a feeling it may not, but I don't know if you can tell us that, Elena.
No, it was not palpable. It
Not
was
palpable.
it didn't blanch, but it was not palpable.
Yeah, okay, thank you. So I'm going to call it now reticular rash. The fact that it's not palpable or blanching, I think this is related to kind of small vessel injury there. Not quite as diffuse and as sort of closed and symmetric as reticularis often is, but certainly is from whatever is underlying with her, but I'm having trouble sort of using it to move in one particular direction. Do you have other thoughts or reactions to the rash?
Not a ton. I had the same feeling of like, even if you just like step away from the screen and look, it's like it's dark, but it's very, very localized, right? So usually like just like the livido-reticularis or modeling that you see so commonly in children too, and it doesn't even have to be in a setting of like very severe disease. It could just be like a vascular sort of blood redistribution phenomenon from stress, from temperature sort of regulation attempts and things. It's often, you know, just a little bit more over a wider area of skin, right? Sort of bilateral, often on the proximal legs, abdomen, whatever. But this just looks, and it's often either sort of like a pink and pale contrast, right? And then the levato is, you know, is blue, right? Sometimes a very light, subtle bluish kind of discoloration, but this is like almost like purple, right? And it almost invokes potential early, you know, hemorrhage or even necrosis, you know, in just pathophysiologically in that sort of vascular distribution, which is why I think sort of the embolic pathophys with levato racemosa as like kind of more complete occlusion can fit with that. As far as tying together with the syndrome elsewhere, you know, in a setting of infectious, sort of an acute infectious, severe infectious syndrome, you know, DIC is one sort of vascular phenomenon that can lead to bleeding or clotting, right? And then when you mention emboli, we should all sort of think about emboli from where, right? And when you think about infection and embolization, you think about you know, the heart valves, which also are another place, sort of source of infection outside the brain that can affect the brain via an embolization, right? So endocarditis sort of definitely kind of is being pinged a little bit in my mind. I think when you think about, you know, DIC, just from sort of fulminant sepsis, meningococcemia, streptococcemia, whatever, presenting in this way, you often see, like, pretty easily see other signatures of that consumptive coagulopathy, right? So I would look more closely at the feet, at the palate, sort of looking for other kind of microhemorrhagic signs, as well as obviously in the labs, we definitely need sort of a platelet as well as coags, potentially a, you know, D-fibrinogen to kind of see if that pathophysiologic process is panning out in the laboratories. Yeah, and Elena, you said essentially this is the only skin abnormality?
So initially it was only on the abdomen appreciated, but it progressed sort of to other parts of the body as well. So yeah, but that was the initial finding.
Yeah, and one just kind of caution I want to give myself here is, you know, the seemingly hyperacute presentation certainly, you know, epidemiologically is like whatever, like very, very likely infection. But at some point I saw a comment in a chat fly by about how this could be an autoimmune debut, which I love. I love that word. But, you know, just keeping in mind that even things that can take a chronic time course, like a lot of you know, autoimmune or autoinflammatory disorders, have to start sometime, and sometimes can start sort of more fulminantly. That's one possibility. The other possibility is sometimes initially we don't have the right history, right? Yes, we know that she's been really sort of sick for a couple of days, but she may not necessarily be able to tell us right now that in fact she's kind of had a little bit of this, a little bit of that, you know, sort of milder version that's been going on for some weeks, and or on and off over months or years. And so I think it's important to question whether sort of the time course that we're, you know, somewhat appropriately anchoring on is actually true, whether we have that data point correct or not. So I think some collateral history in the meantime can be helpful because the sort of vascular phenomena do also invoke you know, immune vascular disease, right? Whether in the form of vasculitis or you know, hypercoagulable states, antiphospholipid syndrome that can present sort of with fulminant catastrophic vascular occlusions in the setting of autoimmune disease, right? lupus or something that would tie together some of the other features. And anyway, so that's kind of in the back of my mind, although still less likely than this just being like a new and very bad infection.
And then you gave us some valuable exposure history on that. I think the residence on a farm in the southwestern United States and New Mexico certainly enriches what she could be exposed to. She's still exposed to things we were thinking of before, right? So as we talked about in the primary CNS category, being worried about viral encephalitides, time of year can help us sort of narrow in, but I think that absolutely could explain everything so far with her systemic symptoms and rash as well. I saw someone mention in the chat in terms of like bacterial meningoencephalitis, Neisseria, I think definitely can be a concern with rash as well. And then, she's in an area where the endemic mycosis we often talk about as cocci. I would be very surprised if this sort of like fulminant systemic infection with a signature that's affecting the lungs. And there are skin findings in cocci, although usually different with erythema nodosum, et cetera. And then some of the zoonotic things, right? We just are on the list now in terms of Coxiella. But again, I don't know how frequently that would cause sort of this mental status kind of collapse as well. And then I love just the point of not totally hanging our hat on that infectious category now, that this absolutely could be other kind of systemic activation for other reasons.
Yeah, Robbie, I've learned this beautiful sort of analogy from him about when he talks about patients with immunocompromise, how the spotlight doesn't shift to opportunistic infections. The spotlight expands to include opportunistic infections. And I think the same applies for travel history or sort of geographic residence in places that we associate with sort of the additional risk of certain organisms, but certainly again, that's also an expansion of the spotlight, right? As you're saying, and patients anywhere are at risk for infection with commensal sort of flora potential, and that's still sort of more common. I think a lot of those like zoonotic infections, when you hear sort of cattle, right, like Coxiella, or if there's sheep or goats or camels, whatever, like Brucella, or when I heard sheep and a dog in the same sentence, and that makes me think of the life cycle of Echinococcus, right, and how we acquire it. But all of those infections tend to have a more subacute or chronic, kind of more insidious presentation. Again, sometimes people just sort of fall off the curve, right? And you might be tricked about the time course, and then in some cases, echinococcus, like if a cyst ruptures or something, you can have a more acute presentation. But it's usually not like this. It can be anyway. This just kind of isn't quite the syndrome. So I think I'm still a little bit more in the commensal space. But I think have we mentioned rickettsia
No,
yet?
not yet. Yeah.
I think that's worth considering, just sort of that can, rickettsia are endemic almost everywhere in the world, and sort of your risk of them is just via exposure to outdoors, right? Sort of fleas, ticks, etc., which are often carried by animals. So sort of close animal contact can further sort of increase your risk for that. And it is a category of infections that can have sort of a prominent CNS signature, both in the form of headache and encephalopathy. And a lot of rickettsial illnesses are actual sort of infectious acute vasculitides. So Rocky Mountain spotted fever, I think, is a prototypical example of where it affects the micro vasculature, and sort of which accounts for some of the manifestations. So New Mexico is a little south of where RMFS sits, but there's rickettsia everywhere that have similar syndromes. I also viral hemorrhagic fevers.
Like Hanta.
Yeah, I'm not super well versed in what fits and doesn't in this case. but something I'd kind of want to think about, especially again when this sting on the abdomen to me looked almost as much like a potential bleed as it did a clot, although hard to say. Can we get can we get some labs, or if in the meantime we'll just sort of catch up with the chat?
Yeah, for sure. Yeah, especially like your point of like, especially in this confused patient, whether it's really a rapid disease or if it's just like a rapid recognition of the disease. And when further talking to also the partner of this patient, it became evident that it was actually rapid. There was like no like preceding illness to this. All right. So for the CBC, the white blood cell count was 6 with a normal differential and a normocytic MCV. The hemoglobin was 13. Platelet count was 38, sorry. Electrolytes and serum glucose were all within normal limits. Creatinine was 3.5 from an unknown baseline with a GFR of 25. T-Billy is 3 with a direct billy of 2.5. ALT and AST are only like mildly elevated below 2 times the upper limit of normal. LDH is 400. Heptoglobin is normal. CK is 1,500. The high sensitivity troponin is slightly elevated at 0.1, but there was no significant delta in the first or third hour. And ECG showed just sinus tachycardia. And the team also got a procalcitonin that was 32 and a CRP of 113, which are both like sky high. And we also got coax studies. So the INR was 1.4, fibrinogen was 500, which is slightly elevated. PTT was 17, which is slightly elevated. The smear showed no abnormalities, like especially no schistocytes, intracellular or extracellular organisms. A respiratory panel was negative for RSV, influenza, parainfluenza, and COVID. And a UA showed 2+ albumin, 3+ blood. A sediment showed 3 RBCs, 5 white blood cells, a few bacteria, and a few granular casts. And a urine tox screen was negative. That's it for the third aliquot.
Elena, you prepared these aliquots? This is your case?
I got this case from like a free source.
Okay.
Cool.
I didn't see the patient, yes.
Yeah. This is a wonderful case, and everything you're mentioning, both abnormal and normal, is very helpful and relevant. Thank you for sharing and presenting this case. What do you think, Steph? What's standing out most?
I'd say the lab that I'm thinking about the most now is the renal failure. Sort of the same way we use the analogy of, the brain can be sick because someone is systemically unwell. You can say the same thing about kidneys, right? The kidneys can be sick because someone is unwell, right? They haven't been eating or drinking, thus they get pre-renal and can progress to ATN. So is it a signature of the primary condition or a bystander is what's on my mind. For how rapidly this person got sick, without a prolonged period of not eating and drinking well or taking a lot of NSAIDs, without a prolonged sort of risk for developing renal injury as a symptom of being unwell, it's on my mind that it's part of the signature of the actual diagnosis that we're working with.
What you're saying is like kind of a proportionality of the degree of volume depletion, hypotension, right, with the degree of renal injury, as well as the fact that it takes time for the creatinine to rise. So like assuming her renal function was normal 2 days ago, right, her creatinine was 1, her GFR would basically have to go to 0 in order for the creatinine to be 2 the following day and 4 the next day.
Essentially, yeah.
So so you're saying, whereas like the patient's like, the pressure is 110/70, right? So so is there an infection that's like directly infecting the kidney or something, or is there some, I don't know, glomerular process that is,
Or vascular
or
process,
vascular
right?
process that is actually has a greater center of gravity in the kidney? Yeah, totally.
So I'll maybe then just sort of tie in how I'm thinking about the UA and then kind of let you comment on some of the other labs we have. She has proteinuria. She's got a lot of heme pigment based on the 3+ blood, not a ton of reds, right? 3. And so important to think about, right? The potential heme pigment could be from the degree of rhabdomyolysis that she has, with that being a myoglobin related. Normally, CK elevations need to be close to 5,000 in someone with normal kidney function to really increase the risk of rhabdo-related AKI. But this woman's kidney function is clearly abnormal. Is there any chance that that is at least playing into the severity of what's going on now, if not the main driver? So I'm struck by the delta between the like heme positive blood and the low number of red blood cells. She does not have a huge amount of pyuria. 5 white cells, I think on most labs would come up still in the normal range. To me, that's a pertinent negative because some systemic conditions have kind of interstitial nephritis as a signature of them. We've talked about, animal related conditions. Leptospirosis comes to mind as one that causes interstitial nephritis, where actually a high amount of sterile pyuria, meaning a lot of whites on the urinalysis without a bacteria growing, is a signature. So the fact that pyuria isn't very high is standing out to me as a pertinent potential negative for figuring out the underlying diagnosis. Anything to add on that, or do you want to just chat through some of the other labs?
Yeah, maybe both. I think in my experience, it just doesn't take a lot of myoglobin to trigger that blood assay on the UA. So most patients with the CK of 1,500, but even like 1,000, even 500 will, if it's acute, will trigger that 3+ blood. Similarly, even a few red cells in the urine, 10 RBCs might be 2+ or 3+ blood. So like it's a very sort of almost oversensitive assay, that dipstick for the heme pigment. So then if you're actually thinking about the glomeruli, I think it's just all about the number of cells, right? So the 3 RBCs, it's something, but it's not, it's very non-specific, obviously. Same with the 5 WBCs. I do think, at least I'm extrapolating a little bit from like allergic interstitial nephritis. I do know that a good proportion of patients with like medication-induced allergic interstitial nephritis don't have pyuria. The UA can be totally bland. So I do wonder, I thought of sort of leptospirosis, right? Like the so-called icterohemorrhagic fever, and the sort of like liver kidney dysfunction. I thought about that too, and I wonder if it's still possible, whether pyuria is truly sensitive for that. I would guess not that sensitive. I saw, I think, Austin, somebody was sort of saying, when you see brain plus kidney, especially if the platelets are down, you got to think about thrombotic microangiopathies. Absolutely, right. And in this case, probably with the prominence of renal dysfunction, HUS is an important consideration. I do think, Elena, you mentioned there were zero schistocytes on the smear, which is reassuring. And then I guess, yeah, I'll just sort of like transition into some of these other labs. So mildly elevated ALT, AST, and the T-bili, elevated LDH, haptoglobin is normal though, and no schistocytes. So probably not intravascular hemolysis. I would guess this is all probably just more from liver involvement and liver dysfunction. And then not a strong signal for DIC. If the PTT of 17, that's kind of low. I don't know if that's supposed to be, is that the PT maybe? Was the PTT? Can we double check that? But I want to just make a note that fibrinogen is an acute phase reactant. So a lot of times in like early evolution of DIC, the fibrinogen will have been starting out pretty high, and even though it's being consumed, it might still be high or normal in DIC. It's on, it's on the way down. It just hasn't gotten low yet. But again, the INR could also just be from sort of acute liver dysfunction potentially, and it's not that deranged. So the platelets are probably the most prominent abnormality in terms of both amplitude, right? As well as if we are concerned about any kind of hemorrhagic complications. I guess, are there some infections that makes more likely?
As opposed to saying thrombocytopenia from just the sepsis, potential sepsis itself. You're
Which
saying
can,
the degree is.
which can happen even without like a overt DIC picture elsewhere,
Yeah.
right?
I don't feel swayed by the degree of thrombocytopenia necessarily, of any of our diagnoses, but curious what you think about the ProCal of 32. I think I missed that on the first time.
That I mean that's not super specific to me.
Yeah.
I think that one could make an argument it maybe favors bacteria over viruses. But it's definitely just a marker of like very severe illness, and there is good data that correlates kind of with mortality and yeah. Would you say anything more?
No, I think it's what leaves many categories still open, not just focusing on bacterial.
Can we do some sort of talk about like next steps here?
Yeah, we should.
Yeah. So let's hear it from everybody in the chat. Thank you, Noah, for calculating the plasmic score. That's for TTP. Great comment about dengue. So okay, so question. What next diagnostics do we need? And then what therapeutics are we initiating empirically? And Elena, while people are answering that in the chat, or please feel free to unmute to anybody, everybody. Would you also just tell me if I missed how the patient's sort of head and neck were on examination, whether there was sort of positive jolt sign, whether the neck was soft or painful, anything like that?
There was slight like rigidity and tenderness, but it was like a whole body pain that the patient was describing. So it was like hard to really like get a sense of whether this is meningismus or not.
Okay, thank you. Okay, who's getting blood cultures? Okay.
Noah's sepsis bundle, Noah says.
Okay, awesome. So Austin and Noah really want to give Doxy. Definitely. I think to me, rickettsia are pretty high on the list. I think thrombocytopenia and LFTs, like it's a signal. The degree of renal failure is a little less usual in my experience, but the risk, the potential, what you have to gain here with just giving the patient Doxy versus what you have to lose is massively imbalanced in favor of giving doxycycline.
And we'll cover our leptospirosis too.
Sure, yeah, absolutely. I don't think it's first line, but it'll be at least like a halfway measure to treat lepto empirically as well. And then when we say sepsis bundle, what do we mean by that? Ooh, good catch, Austin. What traditional antibiotics would you give, Steph?
I would give ceftriaxone. Probably meningeal dosing, and we'll have to
Absolutely.
talk about how we're gonna assess her meninges with her platelets of 38,000, which we should be able to do. But I would do ceftriaxone. I think that would give us nice coverage for Neisseria, other kind of gram positives, right? We've worried just about like high-grade bacteremia being a unifier of this. And I'm thinking very seriously about whether, empirically adding MRSA coverage for her too as well, and this healthy person without risk factors. I don't see that she needs it. I will say realistically, I imagine she might get it in real life just for any concern, right? That this is any gram-positive bloodborne infection, just to cover that because she's so sick. But in the safety of this case discussion environment, I think high-dose ceftriaxone with doxycycline is probably where I would start. Definitely want to kind of image her head because we can't get a good neuro exam to know then if we're okay doing a lumbar puncture. Her platelets are not at the level where we would worry about that driving spontaneous kind of intracranial hemorrhage at less than 10,000. But we've also wondered about, is there any potential for mass lesion, right? Embolic phenomena in the brain. So I think head imaging before examining her CSF is the appropriate move too. And then I don't know if we'll get a chest x-ray or chest imaging, but we never really commented on the 2 liters that she's on now. Does she have hypoxemia as part of this, which could fit with a lot of the diagnoses that we've potentially mentioned, but not all of them. And so actually knowing if this condition has a signature in the lungs too by reassessing her oxygen needs and getting a chest x-ray, I think is important too.
Yeah, I love the ceftriaxone. I think that's just like that's my favorite antibiotic of all time, probably tied with doxy. So giving both is great. But no, I think if you're covering meningitis, that's like 99% of right. But I'm always reminded that like ceftriaxone actually has good activity against some of those like intracellular kind of Borrelia spirochete rickettsial family as well. So we treat right like Lyme carditis with ceftriaxone. We treat syphilis with ceftriaxone if so someone's like penallergic or whatever that tolerates cephalosporins and leptospirosis. So I think that would be the first antibiotic to get into this person's body. I probably would not bother with vanc initially just because the syndrome is just too atypical for sort of staph bacteremia, but it wouldn't be wrong to.
And Lara, I love the reminder about kind of thinking about hemorrhagic conditions like Hanta. So having a type and screen on this woman early, should her platelets become precipitously low or have, she has major bleeding complications is I think, important anticipatory step.
Hey, what does like there's the Cullen sign, Gray Turner sign, Fox sign in like hemorrhagic pancreatitis. Like, did anybody else just kind of think that was
for her rash that she had? It's it was
there's
sort of near her
the
belly button,
the
but
reticular, I don't know, that looked a little funny. It looked more sort of like distant vascular, but small vascular, right? But just
would have expected it to be more ecchymotic if it were like a
I see,
retroperitoneal bleed
just
coming
more
around, more of
okay.
a dense bleeding
Yeah,
area.
you're right. More violet than sort of light purple. Thank you. And then LP, we doing this? I think so.
I think we have to.
Yeah.
You want me to move on?
Yeah.
Okay, great. No, I'm loving the discussion also, like every comment in the chat. So yes, as you mentioned, the appropriate like working diagnosis at this point is like sepsis, like in the context of like multi-organ failure, fever, tachypnea, confusion. And some people might say that like a procalcitonin of 32 is a septic procalcitonin. So at this point, like with the diffuse myalgias and also like some potential like neck pain, like the presumptive diagnosis of septic meningoencephalitis was made. The patient received vancomycin, ceftriaxone, acyclovir, and doxycycline. The team was not as brave as you, so LP was deferred because of the thrombocytopenia. And as you had mentioned, just because of the morbidity, TTP was definitely considered. Plasmic score was done, but it was like a little bit less likely, like with no schistocytes, only like mild anemia, and also like no overt hemolysis on labs. And with the background of the patient, the thrombocytopenia, like potential tick exposure, rickettsial diseases, especially Rocky Mountain spotted fever was, or like doxy deficient state, as we like to call them here, were also considered. So the patient received some further testing. CT head, chest, and abdomen were like with no abnormalities. Patient was screened for HIV 1 and 2, was negative. Serologies for Borrelia were negative as well. The team even did a biopsy of the skin of the abdomen, which just showed non-specific perivascular lymphocytic infiltrates with no evidence of abscess or embolus. And at this point, the lab calls and tells you that the blood cultures are positive for MSSA 4 out of 4. And I'll stop here.
Wow. So I was totally wrong. I mean, you got lucky that it's MSSA and my ceftriaxone, covered it. But anytime there's staph, it's a coin flip, right? It could have been MRSA. So what do you think about putting everything together then? Like, how does this fit? Like, is this, or do you want me to?
The bacteremia should always trigger the theme of the song Cotton Eye Joe. If anyone knows it, where did it come from? Where did it go? Right. So where did this bacteremia come from originally? Hard to say, right? It can come through the skin anywhere in most people, but in this otherwise healthy person, I'm not sort of totally sure what the initial source was. Where did it go? We have cross-sectional imaging already that at least doesn't seem to show kind of evidence of diffuse embolic phenomenon. But if it is in fact on the heart with endocarditis, right, it could be in other places. We've gotten a CT scan, but not an MRI of the brain. So are there actual kind of microabscesses there? So I think for the diffuse kind of organ involvement, I would still be worried about potentially endocarditis causing the severe sepsis and manifestations on this. But I'm a bit perplexed on kind of why she got this in the first place.
I mean, the endocarditis vibes are very strong, I feel like. So because again, tying in the brain with the dysfunction and the vascular phenomenon in the abdomen, which for staphylococcal infection, as opposed to some of these atypical ones we've talked about, usually there's not like a direct, right, vascular dysfunction as part of it. The liver, the kidneys, like I guess we have CT. There's no like big old infarcts in the kidney, spleen, etc. But I'd want to have a closer look at the heart exam, the eyelids, the soft palate, the fingernails, the tip, just sort of looking for physical abnormalities that aren't necessarily sensitive. If you don't see these things, it doesn't necessarily even reduce your suspicion of endocarditis. But if you see them, in this context, it would be very, very specific, right? For sort of a central kind of source of embolization. And you could argue, going back to the abdomen, that is one of those potential findings. So whether this person has a murmur or not, I would want an echo, if not even the better echo through the esophagus if the surface one is quote unquote negative, depending on the quality of the views. Yeah, the question of like where did all this start though is a bit odd. You can get you don't have to have like a very obvious skin source, right, to be the source of bacteremia. There can just be sort of a micro introduction through a cut you didn't even notice or whatever, that then sustains. But it's a bit odd. And then who knows, maybe we don't know all of this sort of health related sort of behavior risk factors for bacteremia. Oh wow, I hadn't thought about sort of
Toxic shock syndrome,
toxic
yeah.
shock and sort of a GYN source. It's a good thought. The degree of renal dysfunction and the liver injury and stuff is kind of
Unless
funny,
it's
I guess.
glomerulonephritis related to endocarditis is one of the immunologic phenomenon.
Which takes time.
Yeah.
Um,
which right, would be seen more in subacute as opposed to fulminant.
Yeah, it can happen with staph, but it's often if you've been like dealing with it for, you know,
Yeah.
a few days, a couple of weeks. Yeah. Okay. So just it's actually a good opportunity to kind of expand a little bit and just review the management of staph bacteremia, by the way. So Steph said you got to think about where did it come from, right? So the source, you want to be able to identify and name one, be that the skin, you know, you can have staph pneumonia that then disseminates, right, and becomes bacteremic. If you have, you know, a chronic indwelling foli or suprapubic big tube, rarely, you know, the urine can be the source of a staph infection, but more commonly, if you have UTI and bacteremia with staph, it was hematogenous and that's not the source. And then you always look at the heart as both a source and a target. And then in terms of sort of more ongoing diagnostic therapeutic management, we need repeat cultures to make sure they clear. We need appropriate sort of selection and dosing of antibiotics. And then we need a very low threshold. And in this case, by the way, once you do know it's MSSA, you would favor a beta-lactam like cefazolin or nafcillin over vancomycin. And then we've already kind of done this, but anywhere that there's sort of a new symptom that you haven't clearly explained, you should have very low to no threshold to image that part and see if that's sort of a new place that the staph has traveled. And I think, yeah, I'm kind of back to the LP. You can have hematogenous dissemination of Staph aureus to the meninges. You can have, you know, I've seen a case of it spreading even to the ventricles and sort of having like, yeah, and again, for a healthy 48-year-old with just staph bacteremia and normal blood pressures, I would not expect this degree of encephalopathy. So if a head CT was negative, great. But thinking about then the meninges or sort of more subtle emboli or abnormalities that might be more evident on an MRI. So I wouldn't let go of that problem as sort of a foregone conclusion. The encephalopathy, I mean.
We've got our wish list. Eleanor, what do you got for us?
Ask and you shall receive. So I'll start with the TTE that showed good biventricular function with an LVEF of 60%, moderate aortic regurgitation with a vegetation attached to the aortic valve. In the course of the hospitalization, the patient also reported back pain. So the team had like a low threshold to get an MRI, which indeed showed spondylolisthesis. So a little bit more on the course of the patient. The patient, because of the size of the vegetation, underwent aortic valve replacement with a bioprosthetic valve and surgical debridement of the spondylolisthesis. And the pathological, like final DX, was infective endocarditis and spondylolisthesis due to MSSA bacteremia. And as you mentioned, like the team couldn't really find the entry site of the staph aureus for this patient, but MSSA was also found in the urine culture. And I think we've talked on VMRs before that whenever you have like MSSA in a patient in the urine that doesn't have like a Foley, you should definitely look for MSSA in the blood. Yeah, and the patient is young and healthy, basically. So it's like interesting that the absence like of overt risk factors. But actually, I read that 50% of patients have like no precipitating risk factor to getting endocarditis. Interestingly, without like any risky behavior, the like further workup revealed that the patient had like extensive atherosclerosis, which is certainly a risk factor also for the valves to get endocarditis, and they're like currently worked up for the atherosclerosis. Yeah, maybe I'll let you reflect, and then I have like 2 or 3 more teaching points.
I think just back to the rash. I'm curious if was there any final thought on whether that was embolic related versus just, you know, libido-reticularis from the severe infection. I don't know if that was clarified at all in her course.
So I think there's a variety of things that can happen with like staph bacteremia, like how you like get this kind of like rash. You can have like the endotoxins that just invade the vasculature and you get this kind of rash. Then you can have DIC, which we didn't see overtly on the labs. And then you can have like all these immune phenomenon. I think most of them are painful, especially like those Osler lesions, they typically are painful. But I think there's a variety of reasons why in this patient the skin looked like that. And if we imagine that something similar happened, for example, to the muscle, then we can also explain the myositis, I think. And you like really like picked up that there were red blood cells like more on the UA than on the sediment, which has to make us like think about like this might come from the muscle, and which is also what the team thought. Yeah.
Thank you. Let's hear the teaching points. Or you had some final reflections, right?
Yeah, I think to me, I'm just sort of recalibrating like the my sort of assessment of the risk benefit of having vancomycin on board for a patient like this, with the information that we had at the time, not having ruled out primary bacteremia, and sort of what about the syndrome made me feel like it wasn't a good fit, right? Sort of the and I think it's just a reminder that staph bacteremia, when it's endocarditis, right, it can definitely just have this like different signature that that has a flavor of a more atypical infection, with sort of disproportionate manifestations in different organ systems that you usually associate with other syndromes, and especially just kind of thinking back to the hyperacuity that like procalcitonin through the roof. Like I think the even if my pretest probability for Staph aureus bacteremia and endocarditis was was 10% or less, like giving a dose of vanc or two is potentially has more benefit there than the harms of a dose of vanc or two. That's my kind of main reflection on the case, just kind of that therapeutic decision making in the setting of diagnostic uncertainty.
Yeah, thank you both so much. I've learned like a lot about just like managing Staph aureus bacteremia from you. And just for the sake of time, I will say just like one more thing because I've already like said some of the teaching points. Something that I didn't know is that up to 10% of patients with infective endocarditis actually have spondylotisitis. And it's also the same way the other way around. So patients with spondylotisitis also need a TTE or a TEE because 10% of them would have endocarditis. And all the other things I've already said. It was really like a great discussion. Thank you both so much.
Thanks for bringing the case. He will turn it over to you for a final summary.
Yes, thank you so much for amazing case. So 48 female with a fever and confusion rash. We have together the past medical history and acute and systemic confusion consider bacterial infection, CNS meningitis, and encephalitis. And the young person's age we have to consider and also consider UTI and apply mist. And physical exam, we found a rash, purple, non-painful, non-palpable, non-blanching, such as vascular issues like vasculitis, necrosis. And we thought about endocarditis, right? DIC embolization and autoimmune, and rhabdoid radiculitis and racemosa was another concern. And we tried to assess the dimer or coagulation study. And then the place the New Mexico patient consider about coccidomycosis, encephalitis, or rickettsia, spot fever, like a hemorrhagic, like a hantavirus, and a farm and animal exposed Coxiella and brucellosis. And during the lab, we found a rapid renal failure, and we consider, and it didn't show, it showed just low pyuria. So we thought about HUS or MAHA, or DIC was less likely, but we thought about leptospirosis leptospirosis and dengue, and chest X-ray, lumbar puncture, and ceftriaxone and high dose doxycycline. We were considered about that, but then the lumbar puncture was not done because of thrombocytopenia, and we forgot about the procalcitonin. It was high, showing the sepsis possibility, and MSA bacteremia and with the end organ sign really suggesting endocarditis, and it was really important to assess like MOMA or skin finding like Jenny Leeson or Sullivan node and neurodeficit, and the TE shows the aortic, moderate aortic regurgitation with the vegetation showing the effective endocarditis. Thank you so much, and it's a flu season, so please take care of your health too. Thank you.
Great message to end on. Thanks again, everyone, for coming. Thanks again for the great case, Elena and Sasan and He, for helping us facilitate the session. Have a good afternoon, everyone.